because today many of our Chinese colleagues and maybe many children's parents will participate in this meeting. So I will introduce in Chinese. Okay? So I'm sorry, Dr. Sholler and Dr. Kraveka. 很高兴啊，今天我们能够参加
Well, I'm so glad to participate in
DFMO 的一个学术论坛。
China-US dual channel on the frontiers in Neuroblastoma. We're so honored to invite very famous Professor Giselle Sholler and Professor Kraveka. Because of these two professors, they are the very renowned experts to initiate many clinical trials on DFMO, and also with the publication of the preliminary data, it is very encouraging. And also we know we have so many pediatric patients go to the US to receive DFMO, and a part of the patients, their prognosis is greatly improved. And in the previously as well as in the following time, well, we hope that the DFMO can be approved in China, and all these children, they would not need to go to the US to receive this treatment. And also we would like to receive the help and support from Dr. Sholler and Dr. Kraveka all the time. And then let me welcome the chairpersons for today's webinar. Firstly, Dr. Wu Yiming from Sichuan Hospital affiliated to Shanghai University School of Medicine, who is the oncology surgeon from the Xinhua Hospital, the former vice president of Xinhua Hospital from Shanghai University School of Medicine, and in the MDT oncologist, MDT in Xinhua Hospital, he is the leader. Welcome, Dr. Wu. And then we have Dr. Sholler. Dr. Sholler is from is the chief of the Department of Pediatric Hematology and Pediatric Oncology, director of the Pediatric Oncology Research, and professor of Pediatrics and Pharmacology at Penn State College of Medicine. And under the guidance of Professor Sholler, they have initiated so many clinical trials and has made great contributions. And today, well, because we have two sessions for the webinar, well, the moderator for the first session is Professor Gaoju, and Professor Gaoju is from the West China Second University Hospital of Sichuan University, and the director and chief physician of the Department of Pediatric Hematology and Oncology, and deputy head of the Oncology Group of Pediatrics Branch, Chinese Medical Association, and also the vice chairman of the Professional Committee on Pediatric Tumor Integrated Rehabilitation of the China Anti-Cancer Association. Well, we also have invited many experts to participate in our panel discussion. They come from different hospitals in China. There are representative hospitals. I will have a brief introduction of all of them. Please move to the next slide, please. Okay, Professor Li Fu from Children's Hospital affiliated to Shandong University, the director and chief physician of Department of Hematology and Oncology, and a member of the Leukemia Professional Committee for the Expert Committee on Pediatric Hematology and Malignant Tumors under the National Health Commission China. Next slide, please. And the next panelist is Professor Liu Aiguo from the Tongji Hospital affiliated to Tongji Medical College of HUSD, PhD supervisor, director, and chief physician of Pediatric Hematology and Oncology Department, deputy director of the Pediatrics Department, member of the Expert Committee on Pediatric Hemopathy and Neuroplastic Disease under the National Health Commission China. So please, the next panelist is from Shanghai Children's Hospital, Dr. Shao Jingbo. And Professor Shao is also the member of the expert committee on pediatric chemopathy and malignant tumor under the National Health Commission China, member of the Oncology Group of Pediatrics branch, Chinese Medical Association. Next slide, please. And also we have invited, we're honored to have also Dr. Guo Xia from West China Second University Hospital, Sichuan University, Deputy Director and Chief Physician, and member of the Oncology Group of Pediatrics branch, Chinese Medical Association, member of the Professional Committee on Pediatric Oncology of the China Anti-Cancer Association. And the final panelist is also from Tsinghua Hospital affiliated to Shanghai Jiaotong University School of Medicine, Dr. Xu Dongqing, who is the doctor from Japan and youth member and of the national level of a committee. So next, I will give the floor to Professor Gao Ju, please.
Okay.
Respected President Wu and Professor Yuan Xiaojun, I'm so glad to have this opportunity to participate in this China-US dual channel on the frontiers in neuroblastoma. Well, actually, we do not have experiences in using DFMO, but today's webinar, I think this is a very good opportunity. And also, we are so honored to have Professor Giselle Sholler in this session to give us on the and Dr. Yuan Xiaojun has already introduced Dr. Sholler, so please.
Thank you. Shall I begin my talk now?
Yes. Yes.
Okay, sorry. Great. Thank you so much for inviting me here to share our work with you. On DFMO, this has been the work of a large group of people, and I'm really happy to be able to share this. Is my screen sharing okay? Here, can you see?
Yes, we can.
Wonderful. Yes. Again, thank you to the organizers for inviting me here to share our work on DFMO. It's my conflict of interest slide. And as many of you here know, that neuroblastoma is one of our most common non-brain tumor, solid tumors in children that occurs in generally children less than 5 or 6 years of age, with the average diagnosis being 22 months. It's one of our most challenging cancers for the high-risk group of patients. As you can see, patients with low and intermediate risk tend to have very good outcomes, but our group of patients with high-risk disease have much more challenging outcomes. And so that's really the group of patients we've chosen to focus on in our research. Our standard of care therapy for high-risk neuroblastoma involves 3 phases currently: induction, including chemotherapy, and surgical resection of the primary tumor. By the end of induction, we anticipate the majority of patients are in remission or very close to remission prior to moving on to consolidation, where they receive autologous stem cell transplant and radiation to the primary tumor area, as well as any remaining metastatic areas. This is then followed by immunotherapy with anti-GD2 antibody. In the US, we use dinutuximab with cisretinoic acid. And the most recent group study from the Children's Oncology Group was our landmark study showing that the addition of immunotherapy improved event-free survival in our high-risk patients, with the event-free survival at 4 years being 54% versus 44% with retinoic acid alone, and the overall survival being 72% versus 56% with retinoic acid alone. And while this is an improvement, 54% remaining in remission is still not enough. That alludes to 45% of patients still relapsing. And so prevention of relapse is something that our research team really focused on, because most relapse patients will die within 5 years. And so DFMO was our drug that we investigated to look at the potential of using this to prevent relapses in children with high-risk neuroblastoma. Understanding why cancer cells relapse is really the cancer stem cells are those cells that take up about 1% of the patient's tumor that are relatively refractory to cancer treatments because they're not rapidly dividing cells. The chemotherapy will affect, in general, rapidly dividing cells, but if the cancer stem cell remains, it can then cause the relapse. And so how do we target that cancer stem cell? One of the pathways that's important in cancer stem cells is the Len28 Let7 pathway. And this is highly expressed in neuroblastoma cells. And we can see the DFMO is a medication that targets ODC, ornithine decarboxylase, which then inhibits polyamines. Polyamines are important building blocks for cells to grow and divide and results in overexpression of Len28 in the cancer stem cell pathway. If we inhibit this with DFMO, we can decrease Len28, increase Let7, which can then also suppress MECAN, which is also very important in neuroblastoma. So we looked at this in cell lines and saw that in neuroblastoma cell lines treated with DFMO, we were able to inhibit ODC. We were also able to inhibit the Len28 as well as MECAN and other cancer stem cell pathways, suggesting that this drug is really targeting the cancer stem cells in the neuroblastoma. We showed this phenotypically by showing that the DFMO was able to inhibit neurosphere formation. So if we put 1 or 2 cells per well in a 96 well plate and treat with DFMO, as we increase the concentration from the red to the green, we see that it inhibits the formation of tumors or neurospheres in the wells. And so in summary, in terms of preclinical work, we were able to show that DFMO inhibits ornithine decarboxylates, decreases polyamines. And some of the work I didn't show was that it also induces G1 cell cycle arrest and senescence in the neuroblastoma cells. It restores the Len28 Let7 balance, as I showed, and suppresses neurospheres, resulting in a cytostatic response in neuroblastoma. So a very different effect than chemotherapy, which is cytotoxic and affecting rapidly dividing cells. This is affecting a different pathway in the neuroblastoma and really focused on the cancer stem cells. Our first clinical trial that we did with neuroblastoma, though, was not in patients in remission. Our phase 1 trials in the U.S. need to be done in patients with active disease who are been told they're incurable. And so we try to test the medication in patients with neuroblastoma and look for any effect. We tested 4 different doses from 500 to 1,500 milligrams per meter squared and found that all doses were safe with no dose-limiting toxicities identified. We treated patients with DFMO for 21 days alone and then in combination with low-dose oral etoposide because, again, these were patients with active disease. The etoposide was given for 14 days of every 21-day cycle. And after 5 cycles of this, patients were able to continue, if they were doing well, on DFMO alone. What was interesting, in about 16 patients on our phase 1 trial, we found that 3 patients were actually alive after 2.5 years of being on DFMO. We stopped the DFMO, and now the 2 boys are in college, and the little girl is in high school, all of them 10 years from finishing study without receiving any further neuroblastoma treatment. So DFMO can have an effect even in patients with active disease as well. But we're really interested in looking at it as a maintenance therapy. And so we did a study with mice where mice were injected with low levels of neuroblastoma cells, and then groups of mice either received regular drinking water or drinking water with 2% DFMO in the water as a maintenance therapy to see if it could prevent relapse or tumor formation in the mice. And as you can see, that in 2 different mice models, we showed that the mice receiving DFMO had a significant decrease in the formation of tumors, suggesting that it inhibited the relapse, as you would say, in patients, in mice. And so this is really what we moved on to into our phase 2 study. After completing our phase 1 study, our phase 2 study was really to be used as a preventative trial in maintenance. So patients who completed upfront chemotherapy, surgery, transplant, radiation, and the immunotherapy with cisretinoic acid, then had the opportunity to enroll on study to receive DFMO for 2 years. This is one of our little girls receiving her first dose of DFMO to see if we could decrease the relapse rate in the first few years after high-risk neuroblastoma treatment. Primary endpoint was event-free survival, and the secondary was overall survival. And just a reminder, this was from the post-immunotherapy trial. The gray bar in the front is where patients received immunotherapy, and then it's at this end of the gray bar where the second arrow is, that's the start of DFMO. And you can see in that first 2 years, there is about a 30% relapse rate. And just as to note, even during immunotherapy, there is about, in the gray bar, during immunotherapy, there's about a 14% relapse rate. But that's not, and that's important for another trial that we're looking at. But here, we wanted to see if we could decrease that relapse rate. That's still a pretty steep curve even once patients have stopped immunotherapy. And what we saw was in our patients who did receive DFMO, the 2-year event-free survival was 85%, and that was pretty flat across at 4 years. The event-free survival was 83%. Our historical control estimate was about 70%, and we could see that it really decreased the relapse rate by about 50%, what we had expected. A lot of people will ask us, is there a difference between MICAN and non-MICAN amplified patients? And over to the side, we can see that the MICAN amplified and non-amplified patients actually had the same curve. It really took away MICAN as a risk factor. Both patient groups had improvement in event-free survival. When we looked at overall survival out to 4 years, we saw that we had 95% of patients still alive. And that was, again, very significant relative to our historical control estimate. This was the main reason. It was actually the overall survival was the main reason the FDA worked with us very closely to see, could we look at this data in a more in-depth way to see is this truly the effect that we're seeing. What they asked us to do was look for a fit-for-purpose external control. And we identified the AMBL-0032 study that I showed you from showing that the immunotherapy improved because the majority of patients that enrolled on the DFMO clinical trial had come directly from that study. If they are at one of our centers, they were able to enroll. So there's patients that were on that study that received DFMO versus looking at the rest of the cohort from that trial that did not receive DFMO as our external control. And again, this is not a historical control because it's the same patient population. So being treated at the same time. When we received the raw database and pulled the patients that were on that study that would have qualified for our DFMO trial, but did not receive DFMO, that left us with 852 patients that we were able to then compare to our 92 patients that did receive DFMO. When we look at patient characteristics, there's very similar patient characteristics across the two cohorts. And then when the statisticians really looked at the event-free and overall survival, it was very similar to what we had expected. At 4 years, we have 84% of patients in remission relative to the historical control, the contemporaneous control of the AMBL-0032 patients of 72% in remission with a p-value of 0.008. The overall survival at 4 years was 96% relative to the control of 84% with a p-value 0.007. So very significantly, statistically significant. But again, this is looking at the whole populations. In terms of safety, just a comment, DFMO having been treated at that point was 360 patients. The main side effect that we see related to DFMO is hearing loss, and it is a reversible hearing loss. So it's important to measure. What's different about it from cisplatin hearing loss is that it's really not only in the high frequencies, it's in all speech ranges. So really more important to monitor for this and to allow it to reverse if it does occur. Other side effects were relatively minor. Some increases in AST, ALT, but not requiring dose changes. Decrease in hemoglobin is seen at higher dose levels. And some dry skin, really, and some hair thinning are the main side effects. But then to move forward with FDA approval, they asked us to do another level of analysis, which was called propensity score matching. Propensity score matching reduces bias when you're comparing data from different sources. It matches individuals from our group to match to individuals that are similar in the control group, and it results in a balancing of the covariance between the treated and control groups. And reduces confounding differences. And so we identified 11 characteristics that were important in prognosis and identified for each one of our patients here in blue, we found 3 patients in the control group that matched this patient based on a propensity score, and every patient had to match on make-in or not make-in amplification. So it resulted in 90 of our patients matching to 270 patients in the control group. When this is done, we see the population characteristics are almost identical because it's really matched patients. It standardizes the differences even beyond the ones that we matched. So prior to matching, the covariates are in green. Once we match the patients, the covariates are in blue, and they're all within 0.1 standardized difference of each other. So the patients are much more similar. And then when we do the analysis, again, the propensity match confirmed the increased event-free survival. So the FDA statisticians did this analysis as well as the company statisticians and came up with these same results, again, showing over 10% increase in event-free survival and 12% increase in overall survival as well in patients. And this is at the 4-year. It continues beyond the 4 years. The curves continue to widen, whereas this stays relatively straight. The historical group really continues to drop even further. We did a summary of many different DFMO analyses, again, all showing virtually the same results. And more sense, and the FDA asked for additional sensitivity analysis, looking at a different propensity score matching, looking at a 1-to-1 model, looking at changing the patient selections. And again, everything on the left side favors the benefit of DFMO versus not. And then you can see the p-values were all significant in the hundreds of analyses that they asked us to do prior to approval. But all of this led to FDA being approved by the FDA on December 13th in 2023, named after 2 children, Will and Finn, so that it is now called iWilfin here in the United States and approved for patients with high-risk neuroblastoma. Again, showing that this is cytostatic, targeting cancer stem cells, inhibiting tumor formation, both in vitro and in vivo model, and preventing relapse in children with high-risk neuroblastoma and increasing overall survival. We do have many other studies now with DFMO, and I'm going to just mention a few of these. Our main study that many of the patients from China are coming currently is for NMTRC-006. This is our ongoing expanded access. This is for patients who are not able to obtain this through insurance in the United States to make sure that all children with neuroblastoma have access to this medication. And it's really for LIN28 and MECAN overexpressing tumors. So not only neuroblastoma patients, but we have many sarcoma patients, ETMR, ATRT, DIPG patients are able to access the drug through this mechanism. We have our NMTRC-014 study, and this is a kind of follow-up study to our study that I just showed, looking at different doses. We're looking at to see if we increase the dose of DFMO, does that increase the event-free survival even further? And so that's continuing to enroll. And then these other ones here, I'm going to mention a little bit more in depth. So the first is the 012 study. This is, as I mentioned earlier, if we remember the curve from AMBL 0032, during antibody, there's about 14% of patients that do relapse. And so one of our questions was, well, what if we brought DFMO earlier and to give it with the antibody and retinoic acid? Could we prevent that 14% of patients or decrease that relapse rate during antibody? This is a randomized clinical trial. It will require 225 patients per arm. And so patients are randomized at the beginning of immunotherapy to receive either dinutuximab just dinutuximab and retinoic acid versus dinutuximab and retinoic acid with DFMO during that first 6 months. At the end of the 6 months, all patients from both arms do receive DFMO for 730 days after. We've enrolled about 80 patients so far on this study, and it is continuing to enroll. Our 015 study is a trial with DFMO and oral etoposide, similar to the phase 1 study for patients with relapsed refractory neuroblastoma. This group, we had a subject, arm 3 is now closed. Oh my goodness. I don't know what I just did there. those were subjects with relapsed refractory disease, so very similar to the patient population that we did use during our phase 1 trial. But we also have arm 1 is for patients who show no active disease after receiving additional therapy for neuroblastoma that initially was refractory to standard or consolidation therapy. So for those patients who are able to achieve remission with additional therapies, they are able to receive DFMO and etoposide. For arm 2, it's subjects who have previously relapsed and are now back in remission or CR2 or greater can receive DFMO with etoposide on this trial as well. Those two cohorts are still open and actively enrolling. We do have some patients. The caveat with this one is that patients do need to come back every 3 months. So it is a lot of travel for patients who are on this study relative to the 006 study. We have our 016 study, and this is a trial with DFMO as maintenance therapy for molecularly high risk or very high risk and relapsed refractory medulloblastoma. There are 2 pathways, the sonic hedgehog and MICAN pathways are both involved in polyamine synthesis and cancer stem cell renewal, and important in medulloblastoma in the group 2s and group 3 medulloblastoma. If we look at outcome by molecular subgroup, we can see there are groups that have very high and very high groups that do have MYC amplification involved that have a very poor prognosis. And we look at the high and very high subgroups here, we can see for molecular risk for medulloblastoma patients with these 2 groups that tend to have that MYC amplification as important, have a very poor outcome. And so on this clinical trial, there are 3 cohorts. The cohort 1 is a molecularly high risk medulloblastoma patients at the end of their upfront treatment. This includes the metastatic non-MYC amplified group 3, metastatic group 4, and metastatic non-sonic hedgehog, but must be non-MYC amplified, and the cohort 2, molecular very high risk, are MYC amplified patients essentially. And then there's cohort 3; those are the relapse or refractory medulloblastoma. They don't fall into a particular category, but they have the opportunity to enroll on this as well. And so these are very specific inclusion-exclusion criteria, but a group of patients that may benefit from this treatment. And then we also have a new study that is opening up next month. This is BCC 020 study. It's a phase 1/2 study using DFMO with another medication, AMXT 1501, as a phase 1, and then followed by a randomized control trial of DFMO with or without AMXT for neuroblastoma. Essentially, DFMO is, as we mentioned, an irreversible inhibitor of polyamine synthesis pathway internally in the cells. But neuroblastoma cells can take up polyamines from the bloodstream through a transporter. And so if we're able to block this transporter with the medication AMXT 1501, it will further lower polyamines within the cells. So the cells cannot obtain polyamines through internal production of polyamines or external uptake of polyamines. And so we looked at DFMO and AMXT in neuroblastomas, and we found that they are synergistic. And when the combination is used together, they inhibit cell growth and decrease polyamines within the neuroblastoma cells. So our phase 1 study, additional work has been done in Australia and MYC and amplified mouse models showing significant inhibition when these drugs are combined together. The primary objective is to evaluate the safety, tolerability, and recommended phase 2 dose of both DFMO and AMXT together. Once that is done, we'll move forward into the phase 2, which the primary objective is to evaluate in a prospective randomized control trial the efficacy of DFMO alone and in combination with AMXT. And we have the randomization is only going to be in the neuroblastoma group. I think I have that here. So there's arm A, AMXT, and DFMO versus DFMO. If the patients, because we do know that neuroblastoma patients may have some effect of DFMO, if they do have progressive disease, they can cross over because they'll have met the endpoint of event-free survival and will still have the opportunity to receive the combinations. There'll be 4 different groups of patients that are able to enroll on this trial. This will be for relapsed refractory neuroblastoma patients, relapsed refractory ETMR or ATRT patients, DIPG patients at diagnosis but after standard of care radiation therapy, and sarcomas, both relapsed refractory Ewing's sarcoma and osteosarcomas. So quite a few different groups of patients that may benefit from this combination that will be opening up next month. Finally, we have one more clinical trial that is opening this fall, looking at Ewing sarcoma and osteosarcoma, and this is the work done by Dr. David Loeb and Dr. Rachel Offenbacher at Montefiore as part of the Beach Healthy Cancer Consortium. They looked at DFMO's inhibition of sarcoma, showing that in these Ewing sarcoma cell lines, DFMO inhibited proliferation, resulted in G1 cell cycle arrest. Inhibited the formation of tumors in cell culture and clonogenic growth assays. They also showed in their mice models similar to ours that when mice were treated with limiting dilution small numbers at 1,000 Ewing sarcoma cells and given either regular water, DFMO, or 2% drinking water, that those with 2% drinking water did not form any tumors versus the water alone, the mice did form tumors. Another interesting mouse model that they did was to look at spontaneous distant metastases. They implanted tumor fragments in bone in the leg of the mouse, and then after a period of time amputated the mouse, and the mouse were able to live long enough to develop metastases. And you can see the ones that did not receive DFMO showed the presence of metastases, whereas those that had DFMO did not develop distant metastases. So this clinical trial is still being finalized, but it's going to look at patients who have relapsed Ewing sarcoma that has obtained local control, either through surgery or radiation. Ewing sarcoma subjects who are metastatic at diagnosis but complete upfront therapy and have no active disease to evaluate the prevention of relapse. High-risk osteosarcoma patients with relapse in the lung after resection of the lung metastases, because their risk of relapsing again is quite high. And then osteosarcomas that have poor response to induction therapy or with a metastatic disease at diagnosis. So as you can see, a lot of new clinical trials are coming forward with DFMO in not only neuroblastoma now, but other indications as well. And I'll stop my talk there. Thank you for again, inviting us to speak.
Thank you.
Okay, thank you, Professor Sholler. It is about the latest updates in the pediatric ND, the challenges we're facing, and also the DFMO, its core data in these different clinical trials. Well, to compare with the historic data, the general OS, the EFS, they can be increased by 40%. And the final part is about some ongoing or the clinical trials in the future, well, just from different perspectives and from different targets through this randomized and prospective control study design to improve the high risk and refractory and relapse NB patients to improve their prognosis. Thank you again for your wonderful presentation. And for this session, we have invited 5 panelists. Well, now it is 9:30. We should end our discussion at 9:55. So here, according to the requirements, maybe firstly, President Wu. We have President Wu Yiming. Yes. And also Professor Kraveka from North Carolina University, and Professor Li Fu from Shandong Medical University Children's Hospital, and Professor Zhang Weiling, Professor Shao Jingbo, and Professor Liu Aiguo. Okay, we have already got we just have the panelists to participate in this round of discussion. So we have President Wu and Professor Sholler. And we would directly start the discussion, all right? We would directly start the discussion. So firstly, please welcome respected Professor Wu Yiming. well, distinguished four panelists and Director Gaojun. And also, I would like to thank the invitation by Professor Yuan Xiaojun. Well, I'm not an expert here. I'm a surgeon, actually, and you are all the oncologist. But still, I'm so lucky, so fortunate that, half a month ago, we went to Huashan Hospital to participate in the World Neuroblastoma Conference. What gave me the deepest impression would be the breakthrough in treating the high-risk neuroblastoma, which is targeted therapy and immunotherapy. Especially, in China, we have already initiated clinical trials on anti-GD2 antibody. So we really felt the benefits to the high-risk MB patients for the long-term OS, less than 30% to almost 50% for the long-term survival. That is the benefit from IO. And also in this conference, this is my deepest impression, especially for two speakers, the two Chinese professors who won the awards because of the study on anti-GD2 antibody. And today, we just see the introduction of another targeted therapy, which is DFMO. I think this is also a very promising medication. Well, after listening to the introduction by Dr. Sholler, I have a very deep impression. We have the progresses in an all-around way, and also we would like to thank the sponsor to organize this webinar. And also, I have listened to Professor Yuan Xiaojun's good news that we are already in the preparation phase of the clinical trials using DFMO to treat those MB patients. And I really hope that in the application of DFMO, Tsinghua Hospital would make its own contribution to this field. And for this high-risk MB patients, I would expect the longer survival for these doctors, and the DFMO would play an important role, like anti-GD2. And after listening to the introduction by Professor Sholler, I also have read some literature. Well, I think that for the DFMO, mainly would have a role in patients with MYC amplification. Those high-risk MB patients, they have the indirect targeting effect to inhibit the synthesis of the peptide. But maybe for other malignant tumors, like all the malignant tumors, they would have the overexpression of the polyamines or the peptides. So I think in clinical trials, maybe for all kinds of high-risk malignant tumors, DFMO would have a role. So I don't know if my understanding is right. So here, I think this can be a question for our further discussion. And thank you all. Thank you. I really look forward to the results we would get from Chinese teams. And thank you. Okay, so please next Professor Sholler. For the final question proposed by Professor Wu, can you respond to that? Dr. Sholler, can you hear the voice? The interpreter is speaking in English channel.
Yes, I just realized the interpreter. So my understanding was the last question is that while DFMO is helpful in MYC and amplified tumors, that there, because of the role in polyamines, there may be a greater broader use. And I completely agree. I think that we really noticed this first when we were looking at our ETMR patients. ETMR are really Lin28 driven tumors. And I think it's that pathway that allows us to have an effect. You know, we've treated about 20 patients now with ETMR through the 006 protocol and have seen some really nice responses. We've done some mice models and looking at the effect on that tumor type is really not MYC driven, but Lin28 driven. So I think it's more the polyamine pathways that can be upregulated in other cancers that the DFMO can have an effect on those as well.
另外我倒还有一个就是问，刚才我看
Also, I have a question that well, I didn't follow. Well, for so many clinical trials, not only in maintenance therapy, but also in frontal lines, right? In induction. Well, what's your comment for these promotion to the front lines? Well, for our original concept would be in the maintenance using DFMO, it would extend the survival and to avoid the recurrence and metastasis. But now I see it may be promoted to the frontier lines. If it is what like anti-GD2, well, I think we also use anti-GD2 in induction phase. I'm not sure if DFMO would also have this path.
好像是联合免疫治疗。
Well, it seems to have a combination use with IO, right?
So yeah, we are combining the DFMO with anti-GD2 therapy, but still in maintenance phase in the end of upfront treatment. Dr. Alice Yu has shown results that the DFMO does improve the immune milieu and the immune response to immunotherapy, and so I think it is safe to give the DFMO with immunotherapy alone. We've hesitated to bring it forward to combine with chemotherapy because in the initial treatment with neuroblastoma, chemotherapy is most effective in rapidly dividing cells. So in really to shrink the neuroblastoma tumors, we want them to be rapidly dividing so that the chemotherapy can be more effective. We worry about inducing cell cycle arrest and senescence because we worry that the chemotherapy may not be as effective in upfront induction therapy. At the most recent ANR study conference, the results were shared of the patients who were on the COG clinical trial that gave chemotherapy and immunotherapy with or without DFMO. And there was no effect of DFMO, no improvement. The rationale, we believe it's because combining with chemotherapy may not be the best combination because we don't want to suppress the cell cycling when the chemotherapy is trying to intercalate into DNA and kill the cells through that mechanism. So I think the mechanisms are just so different that our group definitely wants to bring it where Jackie's study is really bringing the naxitamab in induction chemotherapy. I think that is a very good place to put that, and then saving the DFMO for after for really more as a preventing relapse and maintenance therapy. Jackie, do you agree? Any other thoughts on that?
谢谢。
Yeah.
Yes, no, I mean, I completely agree. And, we think, DFMO is really more like cytostatic, not cytotoxic. And we feel probably, its best place is in minimal residual disease and in the maintenance setting. And like the approach that we're taking in the consortium is our upfront study is now adding chemoimmunotherapy with naxitamab for all cycles of treatment. And then patients can go on and enter CA1-2 study where they get randomized to receive the DFMO and with immunotherapy, and all patients receive it as maintenance.
Okay,
thank you. And it's other panelists' turn.
Panelist 好像我是邀请到的是来自南卡罗来纳大学的是 Kraveka。
Hi, Doctor.
他的音频关掉了，好像没听见嘛。
So please open your microphone. Dr. Kraveka, please.
Okay.
Yeah.
Yes.
Okay.
I didn't hear the question. I apologize.
Okay. 那就这样吧，现在我们最后还有时间一谈，我们现在
他准备回答问题，要他评论还是要他回答问题？
Okay. I have questions to consult Dr. Kraveka. Yeah.
Yes.
Just now, 刚才 Sholler 教授讲了有关在
Well, just
美国
now, Professor Sholler just introduced the series of clinical trials on DFMO.
所以呢，我的问题
So my question is that, well, currently we have very clear answers in the maintenance therapy with the addition of DFMO. In the high-risk NB patients, they would have clear benefits and their recurrence rate would be significantly decreased. Both DFS and OS would be greatly improved. But I see that in the third clinical trial in the NMTRC012, that is during the immuno and chemo with or without DFMO to see their efficacy. Because last month in the ARR conference in Washington, I see you have an oral presentation released. This conclusion is that if with the addition promote the DFMO before the chemo and immunotherapy, your conclusion is that it did not improve the remission rate. So it means that the promotion of DFMO to chemo and IO, the primary conclusion is that it did not improve the remission, the ORR. So here my question is to Professor Sholler or Professor Kraveka, how to comment these results if it is necessary to promote DFMO to frontier lines. Because Dr. Sholler just mentioned that we can do some exploration in promoting it to frontier lines. This is the first question. And the second question is that also for some of the Chinese patients, after they receive a treatment in the US, well, actually they are not using singly DFMO. They can use in combination with chemo in the study of BCC015 with the oral maybe 16. How to choose DFMO to combine in chemo in maintenance therapy, because we have so many Chinese patients that they always have this question. Well, for all these previous treatment using chemo, IO, and anti-GD2, well, if we use DFMO to do the maintenance therapy, if there is a necessity to use in combination with chemo or IO, well, if to use in combine with chemo, what medicine should I choose? These are my two questions, and thank you.
Do you want me to go first, Giselle? I can
Sure.
take the first question. I think
Okay.
the Children's Oncology Group study combined chemoimmunotherapy, irinotecan, temozolomide, and dinutuximab with DFMO in patients with active disease. These were patients who were not in remission. And the report last month at ANR showed that there was no benefit to adding DFMO at that time. And we agree, it makes sense to us, having worked with DFMO, what Dr. Sholler mentioned. DFMO is more cytostatic, and we think it's going to induce senescence in part. And if you have active disease, we really want the chemotherapy to hit the cells well. And so we think DFMO works best in the setting of minimal disease or no disease. And the reason in one of our BCC studies we're doing it in maintenance, starting it with immunotherapy, post-consolidation or post-transplant, is really because in the US, 15% of patients getting anti-GD2 immunotherapy post-consolidation will relapse. So our thought is our going to start the DFMO then. These are patients that are in remission. So our feeling is that DFMO, from our experience, really works best when the patient is in remission. And doing with active disease really we feel is not as beneficial. And I'll let Dr. Sholler take the question, the second part of the question concerning the use of DFMO and etoposide.
Yeah, so with the DFMO and low-dose oral etoposide is what we had studied initially prior to our phase 1 study. We showed that actually the low-dose etoposide was synergistic with the DFMO. So we felt it's different than the higher dose chemotherapy. We have had patients with minimal disease still present, where the combination with the DFMO oral etoposide has cleared the bone marrow or cleared some MIBG spots. So while we wouldn't necessarily recommend it for someone with a significant amount of active disease with low level minimal disease, it has been enough to clear some patients to then, and we only do the oral etoposide for 5 or 6 cycles and then convert to DFMO alone. But yeah, that is our 015 trial that we do have ongoing, again, for patients with, currently now is with patients with only arm 1 and 2, so refractory or relapse, but back in remission, again, with minimal disease. On the 006 study, though, there is the opportunity to combine with other agents because it's simply an expanded access. That trial does allow for, so we do have about 20 patients that have ALK mutations that have been on that trial where we have combined DFMO with an ALK inhibitor. We presented the safety data for that at ANR in a poster and showed that the combination of DFMO and an ALK inhibitor, most common one that we use is lorlatinib, is very safe to give. And we've had patients on both together for 2 years and have done quite well. So there is the opportunity for patients who do have genetic targets to combine with other things as well. Thank you. Is there any?
Thank you very much. I don't have any further questions. It is just the right time. Even though I still have one question, but I think that the time is controlled very well. And I myself is focusing, because for the DFMO, we are focusing for the Lean 28 and the Lean for this like net 7. I'm wondering, for these many of the trial, is there any kind of target for these 2 pathway? And because for the DFMO,
the deprivation of polyamine and have some toxicity profiles affecting highly proliferating hematopoietic cells and liver cells. And this is some kind of concerns. So I would have some kind of elucidation, clarification. Thank you so much.
So my understanding of the question is, with the DFMO affecting polyamines, will it affect the bone marrow cells and other cells as well? We do see, while the standard dose is at 750 or 1,000 milligrams per meter squared is our dose where most patients do quite well. We do use a higher dose, 2,500 milligrams per meter squared for our patients who have brain tumors or who have had neuroblastoma relapse to the brain, because the DFMO crosses the blood-brain barrier at about 30%. So we need to increase the dose to achieve therapeutic levels within the brain. So at the 2,500 milligrams per meter squared, we have seen significant effects on the bone marrow. We do see hemoglobins as within a month go down as low as 6, requiring blood transfusions. It is dose dependent because for those patients, we decrease the dose by 25%, and most patients have tolerated. I've had one patient where I've had to do 2 25% dose reductions for them to be able to tolerate it and not have the hematologic side effects, but it can. And we do see in some patients an increase in the AST/ALT, so it can affect the liver cells. In our trials, the normal for us for liver is 40. We wouldn't change the dose unless it goes over 400. We've seen patients AST/ALT go into the 200s, so about 5 times the upper limit of normal, but then come back down while we continue the DFMO. So it's interesting. It's almost as though they become used to it, and it comes back down to normal. But we haven't had to hold the DFMO or decrease dose because of the liver enzymes, but we have seen an effect on those, yes.
Thank you. Yeah, I got the point. 好，我们这样，我们感谢2位，感谢这个讲者，感谢所有的这个讨论嘉宾。我们第二个环节，
Thank you very much. Thank you very much, our panelists. And for the next part,
您后边这个环节，您没有看到大屏幕，李甫教授、艾博教授、邵劲波教授都有。
Actually, that for this part, that we still have 3 other panelists. So probably that you are using cell phone. So we have Professor Li Fu, Professor Liu Aibo, and Professor Shao Jingbo are also engaged into this panel discussion. Okay, I understand. I probably would like to share first. Thanks a lot for the invitation from the event chair. I have listened to Professor Sholler for the DFMO introduction. We know that we don't have experience using DFMO, but I do have patients enrolled into the clinical trials in the US. Because of the time limitation, I only have one question. You have introduced for the combination therapy with IO and with chemo, and we have a patient and he has received all kinds of different treatment of and then the patient achieved the CR, and around 6 months of receiving DFMO. Based on the clinical trial, there will not be any specific test in between. So the patient did a Python and then discovered some new lesions on the bones. And in his case, our next step should be, according to his clinical trial, maybe he should be just like starting with IO therapy. Do you think? And also, I mean, for the high risk MB, we have some combination therapy possibilities. Like before in this NAR meetings, I have mentioned that there are many of very good targets, like a combination with PD-1 and some immune checkpoint inhibitors. Probably that in the maintenance therapy, like with around 3 months, the patient will just like progress again. So I'm wondering what could we do next?
Okay, so I understand this is a patient that has received, was a refractory patient? Sorry, I'm a little bit confused. What treatments has this patient already received? And was then the patient on DFMO and then relapsed again?
From the imaging, yes, that they have discovered for some new lesions only for the imaging, for the PET, but just have not done any kind of like pathology test to confirm.
Is it possible to do a needle biopsy from one of the lesions to do genomic sequencing to get further understanding of this patient's tumor at relapse? Can someone translate?
Okay, yes, thank you very much.
Is it possible to do a needle biopsy for the patient's tumor at this time?
It will be ideal if the patient can do needle biopsy, because for this kid, only there is lesion appeared in the imaging, but however, the good is in like very good condition. So the patient is very satisfied so far. So do you think we can wait, or we need to actively intervene with these new lesions?
Where is the lesion?
Just like iliac bone. And actually, if we can conduct like a bone marrow, just like biopsy, that will be perfect. But however, for that location might be tricky.
Yeah, if it's possible to do bone marrow biopsy, that would be helpful. If you can do the biopsy and do the decalcification in EDTA instead of acid decalcification, that can then be used for whole exome, whole transcriptome sequencing. We can do that for you if you need. Many of the patients from China now are bringing tumor samples for us to do the more in-depth genomic analysis, or you can probably do there too, to have a molecular tumor board to look for what is the best targeted treatments for that patient, if that's possible there. We'd be happy to work with you with this patient also if you would like. The other options that we use in a first relapse like this, I wouldn't wait in terms of treating. We would treat. If it's a single bone lesion, often we will do radiation. If you can, low-dose oral etoposide or vorinostat are both radiation sensitizers. They show that with vorinostat with MIBG, it's a very good radiation sensitizer. So often if we have a patient who relapses in just one or two spots, we'll do that to radiate, and often the children will be back into remission. Our standard treatment for relapse treatment is often irinotecan, Temodar with antibody therapy for about 5 or 6 cycles. That's one option, but there are other options that we use for relapse patients, like oxaliplatin with doxorubicin have shown very good responses often in other patients, but I'd be happy to talk with you more about that particular patient if you wanted to look at the genomic targets to see if there's specific drugs that might be best for that person. Jackie, do you have any other comments too?
No, I completely agree. It's just same approach you would take, and sometimes the relapse patients will develop an ALK mutation that they didn't have a diagnosis, and you have a targeted therapy there. But I guess our approach is usually we sequence home exome transcriptome, try to get something targeted, and then chemoimmunotherapy, and then based on sometimes, like Dr. Sholler said, perhaps if it's just one area, radiation is another option too. But I would do something. I would recommend doing something because sometimes these children, they can be indolent, but they can progress rapidly. So I would do a bone marrow and then go from there, and then try to if that's negative, still see if you could do perhaps interventional radiology to do a biopsy, so that then the tumor can be sequenced. But I would not observe. I would try to do some treatment for the child.
好的，好，谢谢。
谢谢。
好的，那我就接着来吧。首先感谢袁主任主持的这个会议。
Okay, well, firstly, I would like to thank Professor Yuan to organize this meeting. Well, I will directly give the question. Well, firstly, something that to share some of my feelings. Well, firstly, DFMO. Well, it is an irreversible inhibitor of DFMO, of ODC for the DFMO. So it means that although it would influence cancer stem cells, but for so many times, well, for the stopping of the cell cycles, well, more it is they would just into a senescence period of the cancer cells. So it is not like the traditional chemo or anti-GD2 would directly kill the tumors. So from this perspective, that during our discussion, well, if we can promote it to front lines, well, for the still it is about chemo and GD2, and for their influence to the sensitive cells. And its mechanism of action, well, more relies in to stop the cells from differentiation. So for the existing tumor cells, I think to kill the existing cells, it is not very good, or it is not a main role for DFMO. Well, for this background, well, because I also have done some of the studies related to the cell cycle, well, I would talk about the other question is about DFMO. Well, they would have some drug resistance problems for the DFMO. What about the mechanism of drug resistance? What aspects they are involved for the DFMO resistance? Because we also do some clinical trials. Well, for these different clinical trials, well, they would influence the polyamines in the blood, but actually for the polyamines, well, they would still have some effects in those normal cells, for the normal cells proliferation and other activities. So here I think that if from the different MOAs, well, if we can try from the different combination therapies, or still focusing on the target of a polyamine, if they would have the addition of the adverse events of different drugs in the combined use modality, or the influences or the adverse events to the normal cells when used in combination with others. So this is my question.
Okay, so my understanding is the question about how the cells can become resistant to the DFMO, and then the combinations, and we definitely, while we're able to inhibit with DFMO the relapse rate by 50%, there are, from instead of 70% of patients in remission, we have 85%. There are still 15% of patients that are relapsing. So we're not able to completely inhibit the relapse rate. So DFMO does not work for every child. And so there is an understanding that mechanism of resistance for those patients that do relapse and we're not able to maintain the remission for is definitely an area that we are studying in the lab. While the cells do induce senescence, and one of the studies that we're hopefully opening in the month or so will combine the DFMO with the AMXT. Again, the cells can take up polyamines from the bloodstream, and so by blocking the uptake inhibitor, the receptor, that might help prevent some of the resistance, and by taking up polyamines from the blood. Dr. Hoverty has looked at the study of doing a low arginine diet. That may be another mechanism that the cells are taking up the arginine and creating polyamines that way as well. We are looking at DFMO, as it induces senescence, the cells may kind of revert and at some point. So we are looking at DFMO and combining it with senolytic agents. So if we can induce senescence, there may be agents that are senolytic or cause cell death in senescent cells, such as venetoclax or other drugs that can help further induce that cell death that we don't see with DFMO alone. And so some of our research in the lab shows very significant promise in that combination as well. So there are other drugs, but yes, in combining those with other drugs, we may induce further toxicities. There was a clinical trial with DFMO and AMXT in adults with the oral combination of both was shown to be safe, but when they converted to IV DFMO, which increased the DFMO levels significantly high in combination with the AMXT, they did have some cardiac events, and so definitely had effects on cardiotoxicity. And so that's something we want to try and avoid, obviously, in pediatrics. And so the dose of the DFMO does matter, and the higher dose, we can't just keep pushing the dose up too high because it does have significant toxicity, as we've seen in the hematologic toxicity and the adults have seen in the cardiac toxicity. So while we can stay at a safe range of DFMO to alleviate the resistance that we see in some patients, I do believe it's combination with other medications that don't have overlapping toxicity that is going to be more important to do. But that's definitely an area we're researching significantly right now. 谢谢。
那么接下去就我来，非常感谢袁小军主任和
I'd like to thank Professor Yuan Xiaojun and Professor Wu Yeming, and also I'd like to thank the two professors for your lecture and for the DFMO as clinical applications. I have 3 small questions to ask Professor Sholler. Well, the first question, it seems that, for the auditory, for the listening capability as an influence, it would be very obvious, but you still say that, it is irreversible. But to what degree, it is still reversible, or to what degree we should consider the reduction of the dose of DFMO? This is the first question. And the second question is a combination with IO. If we use it together, well, we would use it in the same time, or when doing the IO, we would stop DFMO, or it is a continuous use for both of the two drugs. And for the patients with meningeal metastasis, well, the dose can be as high as 2,500. Well, compared with the maintenance dose, it is a large increase. So at this dose, it would continuous use or just using several days in a cycle. This is the third question.
Okay. So the third question in terms of combining it with
听力受损的话怎么减量？
So the first question is about the adverse events to the listening capability of the
yes. Okay.
patients.
So the hearing toxicity one. What we do is we try and monitor if the patients have symptoms at all, we recommend getting an audiogram. We always have a baseline audiogram before starting DFMO, and then at 6 months and at a year. But if the patients notice any change in hearing, we recommend checking an audiogram sooner. If we see a 20 decibel decrease in hearing in 2 contiguous dose levels, we will repeat 3 weeks later to confirm that. And if we see that, then we would hold the DFMO for 30 days. Generally, it takes about a month for the reversal to increase. We don't want it to go more than 20 decibels. If it goes too far, it does take much longer to reverse. And so ideally, we don't want to see more than once we're about that 20 decibel, that takes about a month to recover. And so that's important to monitor for that. But ideally, the sooner that you can notice it, the faster it will reverse. And so that's why if families notice it, if their children are turning their volume higher on the phone or on the TV, something is different, and then we recommend checking it sooner. What was the second question again? No, so there's 3 questions. The third one.
就是免疫治疗共同用的时候，它是
Well, when it is used in combination with IO, well, when using IO, we should haunt the DFMO, or we just continuously use them both.
IO, do you mean the
Immunotherapy.
Oh, immunotherapy.
Immunotherapy, yeah.
Immunotherapy we do at the same time continuously. We don't when we're doing it with the immunotherapy with retinoic acid during maintenance phase, we continue the DFMO through the whole time, and it's been well tolerated. Again, Alice Yu studied that combination in many different. She published one paper showing that the DFMO actually helped with pain with antibody and also increased the immune response. And so we feel that it's been quite well tolerated in our patients. Since we're doing it as a randomized study, we can compare the adverse events of the immunotherapy with retinoic acid group with immunotherapy, retinoic acid, and DFMO, and we don't see any increase in toxicities with the addition of DFMO so far. So it's been well tolerated. And then the third one with the leptomeningeal disease with the 2,500 milligrams per meter squared. Most patients, 75% of patients do well without any toxicities. About 25% of patients will have toxicities, hearing being the most common. But I've had many patients now with CNS neuroblastoma where we have given the 2,500 milligrams along with intra-Omaya triple chemotherapies, and it's been really well tolerated together and with immunotherapy at the same time. So we do for our patients that have neuroblastoma, CNS neuroblastoma, if they can get a resection, then they get craniospinal, then they do intra-Omaya with high-dose DFMO and immunotherapy. And we have quite a few now long-term survivors with that, so it's pretty well tolerated. Thank you. 谢谢。
那这个2500的剂量用多少时间啊？一般
Well, what about the time for using this high dose to 2,500?
The time, what do you mean?
So about the duration using this high dose of 2,500.
Oh, we do it for 2 years. Every day for 2 years.
哇塞，好的好的，谢谢，我的问题
Okay,
谢谢，
thank you.
非常感谢。
These are my questions. Thank you so much for
Thank you.
explaining. Thank you.
好，我们感谢所有的讨论嘉宾。
Okay, we'd like to thank all the panelists, Professor Sholler
这个教授，谢谢。
and Professor
环节
Zhang. And let's enter the next session. Please welcome Professor Yan Xiaoqing as the moderator for the next session. Well, I'm so glad to have all the speakers and panelists participating in the first session. Well, for the second session, we will do some case reports. So firstly, we would invite Professor Guo Xia and then Professor Xu Dongqing. Well, after your case reports, we would have a panel discussion. And also, please, Professor Sholler and Professor Kraveka to comment on these two cases. Okay, thank you for your introduction, Professor Yuan, respected chairperson, and all the experts online. I'm so honored to have this opportunity to participate in this webinar, to have this communication.
And I'm going to share a case that is diagnosed and treated in our hospital. Can you see my slides? Yes, please make it full screen. Okay, thank you very much. So for this, for the topic is actually for a case of a pediatric MB with a therapy-related AML, clinical insights and management. So this is a 4 years and 5 months female patient admitted to the local hospital due to recurrent fever accompanied by the enlarged left retroauricular lymph node and pain in the both lower limbs for over 1 month. The blood test result is moderate anemia elevated CPR. And for the knee MRI, seeing for the abnormal signals in the middle and the lower segments of both femurs with surrounding soft tissue swelling suggestive of the infection lesions. Abdominal CT, there is a mass in the left adrenal just like glands as suspected with MB. And we can see that the local hospital administered anti-infective treatment with poor efficacy. And the patient was transferred to our hospital. We can see that for the contrast enhanced CT have detected a soft tissue mass with calcifications in the left retroperitoneum suggestive of MB. And for the patients like brain MRI with contrast also have seen multiple abnormally enhanced foci in the cranial facial bones and then and also where this like thickened and enhancing for this like meninges with a markedly enhanced nodule in the right frontal lobe. And we can see for the imaging, and we suspect the patient is having a INSS stage 4 and high risk group, just a group. And we have followed and with the like GPOH and BL 2017 high risk protocol. So we have initiated with the chemotherapy with 4 cycles, N5 and N6 chemotherapies. And for the MDT like assessment and has evaluated the patient's surgical indication. And the patient have a clinical improvement, and she has like a resolutions of a fever and also bilateral just a lower limb pain. And for the serum NSE has declined, and the imaging has showed the significant like a mass shrinkage. And also we can see after for the treatment or after for this like continued chemo for the PET CT have find complete metabolic response. And for the MDT carried out afterwards is having the discussion and having the assessment of CNS radiation indications and the target volume like delineation. And we can see overall incidence rate of 1.7 to like 11.7% low at initial diagnosis. Chemo drugs have difficulty penetrating with the BBB, and we can see that making for the CNS a potential just like a difficult for the MB. Currently, there are no particular effective treatment options, and so far that in China, that based on the suggestions or like just recommendations of the guideline and consensus, the external beam radiation therapy would be the standard of care. And we can also see that if we having a more comprehensive like external beam radiation therapy, and then for the diagnosis and also for this radiation treatment, it can be lower to the 18th grade if we have the CSI with local boost. So we can see here that the patient underwent the local radiotherapy, primary tumor bed, and also skull metastasis at West China Hospital. And in July 2020 to 2021 March, then we have like provided to the patient with maintenance therapy with 13 cis-retinal assets. And we can see that in like March 10th, 2021, the patient developed cough with just a sputum production and a recurrent limb pain without obvious cause. The complete blood count is 4% like blood detected. And we can see that for the MRD and also with this morphology in bilateral bone marrow with persistently negative serum NSE is continued decline. And there's no abnormalities in the CT. And we can see for those blood and for the patient's imaging. And actually, on March like 19th, we can see the patient's like test result. And we can see that we are having for the doubt, like whether this is a like a second malignant tumor. We have checked regarding to this like definitions of the second malignant tumor. And in MB, for the incidence of SMN in MB is approximately 0.88% to 10%, with a risk 2.8 to 10.4 times higher than that of the general population. And commonly affected site, including the digestive system, bone and joint, urinary system, like nerve systems, endocrine system, and others. The most common type is for the thyroid cancer, therapy-related acute, this like myeloid leukemias, and for the secondary like malignance are common with the first 5 years after the treatment. Because of the toxicities of the medication, and then we can see it can also trigger for the top inhibitor, just like potential for these risks, and then it will occur within 1 to 2 years. And also we can see like all from like chemotherapy drugs or like radiotherapies, or having for cytogenetic changes and also generic like susceptibilities. And then we still can see for some potential risk factors. And then this is for the case, just presenting some regarding to the treatment course of the TAML. And the patient underwent 4 cycles of the chemotherapy according to the high-risk protocol CCLG AML 2019 with intrathecal injection administered 1 per cycle. And we can see the patient so far, no matter for the AML and MB, and is continued to have the response and very well managed. So the patient has returned to school. So the summary of this case is that we know the patient have quite young age at onset, and for the diagnosis is actually for the high risk MB, and the patient has a multiple just like cranial bone lesion with suspected like a brain parenchyma involvement, but no neurological symptoms. And the local just radiotherapy to the skull was like administered after chemo. And for the complex disease causes that the patient experienced a multiple stage of MB diagnosis and treatment. and followed by the development of a second malignant just tumors, which is transformed AML. Both MB and AML has achieved continued complete remission to date. The fourth one is that timing to the second malignant is like neoplasma occurred 18 months after MB diagnosis. And we can see that the patient has no family history or cancer or like genetic susceptibilities. And for the MLL, AF9 and EV1 positive were identified. The primary cause of the TAML is considered to be chemotherapy related, with the role of like radiation therapy uncertain. And the patient received the chemosurgery radiation therapy and also with this AST CT. And we can see that there are two questions is like worth us to have the discussion. One is that what is for those risk factors, potential risk factors for the development of the therapy for this therapy-related AML in the patient with MB? How can these risk factors be identified and mitigated early in the treatment course? The second question is management of the CNS involvement in the MB. Given the initial CNS involvement in this patient's MB, what strategies should be considered for treatment and prevention of the CNS recurrence? How effective was the local radiotherapy to the skull in preventing CNS relapse in this case? So this is our team, and then we have conducted some like studies and trials in the field of MB. Thank you very much. Thank you, Professor Guo, for your very wonderful sharing. Because of the time limitation, we would like to invite Dr. Dongxing to share the second case, and then we will have the discussion together. Distinguished Chair and all of our experts, I'm very honored to be part of this conference. And I would like to share with you a case that is diagnosed and also treated in our hospital. And this will be my talk today. And the first one is for the case report. This case is a 6-year-old boy. For the chief complaint is presented with abdominal pain and distension and fever for 10 days. And we can see for the patient, like PET MRI has showed the pelvic, like a sacral anterior malignant tumor, multiple enlarged lymph node metastasis, and the metastasis of the axial and peripheral bone marrow cavities. And the abnormal, for this like abdominal like vascular CTA showed the mass surrounds the inferior vena cava and abdominal aorta. The history that the patient with diagnosis was congenital, is like a megacolon. And we have done a biopsy from the right like inguinal lymph node. So actually we can see that for if combining with this like for this like morphology, we can see the small round blue cell and a high nuclear to cytoplastic ratio and arranged in the sheets and just like rosettes with just like neutrophil. And also we have done for the just chemistry like test, and also we can see it is a fit for the diagnosis of the poorly differentiated MB. And we can see this is for the guidelines, and also we can see for the induction therapies. And after the surgery, this is for the surgery we have done for the pelvic malignant tumor resection and combining with the retroperitoneal lower posterior like medial just like stenos and inguinal lymph node dissection. And for the post-op pathology is consistent change in the MB after chemo immunohistochemistry and the like molecular just genetics. So we see a 1P related missing positive. The patient is having for this MIBG is like 0. And also we can see the patient's DOTA is negative. So the bone marrow just like examination showed a negative. And so we determined that for the evaluation after the induction therapy is a CR. And afterwards, we have done a radiotherapy. Afterwards is the maintenance therapy, 2 cycles of the maintenance therapy. And then we have identified that there is a subcutaneous nodule on the left occipital lobe, approximately 0.6 centimeter in length, suspected of the metastasis. And so this could be determined as relapse. And then we have seen for the ALK has shown a strong positive. So we have combined with lorlatinib. And afterwards, we have also done for the assessment regarding this. So this is the therapy plan after relapse. And after for the treatment, we have seen the bone lesion has disappeared. But however, for the subcutaneous nodule, it's similar to before. So the evaluation outcome is a PR. And after we have conducted for the chemo immunotherapy, and then we have conducted for this DOTA examinations, except for the small lesions. And then there are other multiple lesions were significantly reduced. So for the evaluation is a VGPR. And afterwards, we still have seen some slightly enlarged subcutaneous just like nodules. So the evaluation is a PD. And the patient underwent for the surgery and on 12th of June. And then we can see that after for the surgery, so we have conducted for the MDT discussions. And then it's 4 cycles of the IO therapy. We have done a systematic evaluation. And however, for the DOTA has identified there is a new soft tissue thickening at the level of the left second anterior rib. So the patient underwent for the surgery again, and then we have conducted for the chemoradiotherapy combination. Afterwards, for the assessment by the chest MRI, head MRI, both of the tests are negative. So the patient's diagnosis have returned back to CR. So we have just completed 2 cycles of the just IO combining with chemo. So for the latest DOTA has showed that there is no obvious recurrence or metastatic lesion. So the overview of the treatment is that the patient have underwent for the standard chemo, and then the patient achieved for the standard just like CR, and then the patient have not received for this ASCT, only received for the radiation therapy. And afterwards, the patient occurred for the first relapse because there is a newly developed bone metastasis, and for the intracranial just submucosal metastasis nodules. After for the MDT, and then the patient underwent for the surgery and again achieved the CR, and 4 cycles of the IO therapy, and then the patient has detected with a new soft tissue thickening at the level of the left second anterior ribs. And then the patient received the IO plus chemo, and then the patient achieved the CR again. So there are some risks in this patient's treatments. It is a difficult surgery because the patient has a previous history of the congenital for this megacolon and the mass surrounding important blood vessels. And the patient also after the surgery, the patient had infections. And after the first therapies, the patient also is having the intracranial metastasis. So it also has put upon for the difficulties, and also the patient was having for this malnutrition. So within the MDT assessment, and then the patient currently the boy is a P75 regarding to this nutrition terminal state. So discussion of this patient is why does this boy relapse repeatedly? The patients for his like amplification is negative. Is there anything related to the deletion in like 1P? And because the patient is ALK positive 3+, so we have combining the treatment with like vorotinib. And according to this boy has underwent 11 cycles of immunotherapy. Is it necessary to continue IO for the patient who is currently taking like vorotinib orally at the CR status? And third one is we wanted to issue the patient DFMO maintenance treatment. But however, this patient have multiple rounds of the like relapse. So how to prevent recurrence in the future? Whether we should combine with like a chemo for like multiple rounds?
Okay, thank you, the two speakers. These are very great case reports because time is limited. Well, in addition to invite Professor Sholler and Professor Kraveka to give us comments, and also we have invited the professor and experts who are very famous in treating the refractory and recurrent MB in China. Firstly is Professor Zhang Weiling, and who is really good at treating the refractory and recurrent refractory solid tumors. So first section, please, Professor Sholler and Professor Kraveka and Professor Zhang Weiling to discuss. And Professor Wu and Professor Gao, we would have a further discussion. Well, firstly, please, Sholler.
Please remark the two cases. Thank you.
Thank you. These are both very interesting cases and very, very challenging. In the first case, the secondary AML is not something we see very commonly, but is definitely something that we see more commonly here for patients who've had MIBG therapy treatment. We see that in one of the published reports on MIBG therapy, it was up to 12% of risk of secondary leukemia. This case, obviously, she did not have the MIBG therapy, but most likely related to the etoposide or given the early relapse or early secondary malignancy with the AML, and it sounds like she's had really terrific treatment for that, and is doing well. So I think very, very interesting case and very unfortunate, but it sounds like she's done very well. For the second case, very interesting, given the intracranial relapse being first and then the next relapse being outside the cranial, suggesting that the surgery and the radiation was very effective on that patient. That's someone that we would consider doing the intra-Ommaya chemotherapy, the intra-Ommaya chemotherapy that we use for patients who've had CNS relapse is etoposide 0.5 milligrams with iotepa 5 milligrams and the topotecan 0.4 milligrams, so triple chemotherapy. In the Ommaya, we start 2 days per week for 3 weeks, followed by a week break, and for multiple rounds. But that's something that we've started doing with the team at Sloan Kettering. They're doing that as well. We learned from them and have seen some patients, with long-term without further relapse in the CNS. Although this patient has done well without relapsing already in the CNS, so I don't know that it's necessary at this point. But it is someone that we would recommend continuing the lorlatinib given the ALK as well as the high-dose DFMO because of the CNS relapse, and the chance that this patient will relapse again is very, very high. I agree with some form of maintenance therapy, whether it would be the DFMO. This is one that we would probably do the DFMO with the low-dose etoposide. This patient would qualify for the 015 study if they weren't going to do the lorlatinib, but if we were going to continue the lorlatinib, it would need to be on the expanded access study to do that. But yeah, I would continue something for this patient, given this is a very high risk of relapse, but it sounds like the patient's done just really well with the treatments to date. Jackie, I guess.
This was really wonderful case presentations, and I'm happy that both patients are doing well. I think for the first patient it's rare, and usually we see this therapy-related AML occurs a little bit later, but this occurred pretty rapidly. And I had a similar patient probably about 15 years ago who unfortunately, relapsed after stem cell transplant for AML. And these are rare, and they're so difficult to treat. I wonder, was the KRAS mutation seen? We've seen some neuroblastomas in our sequencing that have a KRAS mutation. Do you know if there was a KRAS mutation in the primary neuroblastoma?
Yes, they have done some genetic testing. Well, when there is AML, we just set the primary lesion sample to do NGS. There is no mutation for KRAS.
Okay, I was curious. I know sometimes we see that in neuroblastoma, but I'm glad your patient is doing well. And in terms of the second patient, these are always so tough. I know you have a lot of ALK overexpression. I don't know if there's ALK amplification, but there's theories years ago showed that the patients with ALK amplification actually have the worst outcome, worse than those who have an ALK mutation. So we know that ALK is one of the even patients up front who in the PSYOPEN study, even those who received dinutuximab beta and had either ALK mutation or ALK amplification had a worse outcome. So I'm glad that you're able to give lorlatinib to this patient. And I do agree. I would probably continue. And sometimes I do an extra couple cycles of immunotherapy of IO just to keep that patient in remission. And I agree with Dr. Sholler. This patient really be an ideal candidate for the high dose DFMO, given that they had a history of the CNS involvement. But very interesting, and I'm very happy to hear that the two patients are both in remission right now.
Thank you for your comments to our case reports and also your suggestions to our following steps. And then next up, please welcome Professor Zhang Weiling to give some comments to these two cases. Okay, thank you for your introduction and your invitation. Well, for Professor Sholler and Professor Kraveka, well, no matter about the lecture on DFMO or the comments to the cases, well, generally speaking, I think, by Dr. Guo and Dr. Xu for the case they presented. Well, for the first case, well, actually, we have several MB with the secondary myeloid leukemia. Well, currently, after the transplantation of the bone marrow, they have already reached complete remission for 2 to 3 years. But generally speaking, we also have other secondary tumors of other tumors during the treatment. And also we found that by Professor Kraveka, about the KRAS mutation, well, for the solid tumors, well, if there is mutation for KRAS, there is a possibility for the following secondary myeloid leukemia. We have other tumors to prove this point, including MB. Well, however, for the second case, there is no KRAS mutation. Well, I think for the other therapies, they are very successful. And for the intracranial prevention, we are always exploring. Well, firstly, the first line we should prevent. But if we have the recurrence, still we should do the injection of the chemo into the myelins. Well, for the accessible chemos, still we have the triplet regimen to treat leukemia. It's an MTX. And also we have the topotecan-based chemo to do the injection. And for the Setipad, we have tried, but including some of the adult medicine of pemetrexed, we have tried, but the efficacy, well, I think topotecan is more effective for the public recognition, and for etoposide, we do not have the accessibility to this medicine. Well, we only have some medicines who bring from foreign countries. And for the second case by Dr. Dongqing, well, this is a very excellent and very successful case. Well, my question is that for the intracranial metastasis, if it is related to the bone metastasis, yes, the answer is yes. Well, yes, so actually it is bone metastasis. Yes. So previously, well, actually for this time of recurrence, and the most of the recurrences, they are related to the bone. Actually, they are bone metastasis. So I think for bone metastasis, well, it is a very, very difficult point for MB. Well, from Dr. Guo, well, I think for the submeningeal metastasis, well, here now I have a case for the whole meningeal site. They have the metastasis of the MB. It is really difficult to remove those metastatic lesions. Well, not only radiotherapy, we also did a surgery to remove those intracranial, those meningeal metastasis. And for the, well, because of our case, well, the area of the meningeal metastasis is too large. It is impossible to do the resection. Well, actually, for the first case, did not receive surgery, and before radiotherapy, well, actually the lesion has already been controlled. So that is after the chemo, they get the remission. But because the area is so large, for our case, for the full meningeal, there would be the metastasis. It's really difficult to treat. I also want to ask, have you ever met the cases with such large areas of the subdermal metastasis? Well, I think still the prevention is to do the prevention. Well, if we can consider, well, the DFMO, well, maybe firstly we should consider the price. Well, if we use a 2,500, well, the expense would be very much. Well, if maybe there's a oral telazolomide or the etoposide, and for the brain tumors, using thalidomide or the other medicines to add in the treatment. Well, I think this is also a place that we should explore. Well, Professor Yuan also suggest how to choose. Well, also like Dr. Gou has mentioned about the HDAC, that is the HDAC inhibitor, and also for the AML, for the BCL2 inhibitor, the venetoclax. Also, some of the doctors, they have tried in the bone metastasis. Well, actually, I have several cases only with the single medicine. Well, they have some efficacy, but specifically, we do not have a lot of cases. So these are my comments, and thank you. Okay, thank you for your excellent comments. Well, Dr. Gaoju, any comments to the two cases? Because time is limited, and sorry. Well, Dr. Gou. 教授现在是静音状态啊。Okay, well, because time is limited, Dr. Sholler and Dr. Kraveka. Okay, thank you. Well, this is the end of the case presentation. I know that all of you have very much questions, including the brain metastasis of the bone metastasis, the meningeal metastasis, how to deal with them. Well, especially for the case, well, about less than half a year, they would have the secondary AML. Well, maybe in the future, we still have to optimize the early stage treatment efficacy as well as the responses in the final section. Well, firstly, we would like to invite Professor Weiling to give us a conclusion of the webinar. Professor Wu. Okay. Well, just we will invite Professor Sholler. Well, I would have two sentences. So firstly, thank you so much for taking your time to participate in this Saturday webinar. And I think this is very helpful for our clinical practices. And secondly, also we would like to thank our sponsor and also the two speakers from the US. Well, actually, this is already very late at night. Thank you again, Dr. Sholler and Dr. Kraveka.
So please give us a review. Thanks.
I just wanted to thank you, and it's really an honor to have participated and to be part of this. Thank you so much, and I look forward to meeting you in person in Shanghai in 2 years. And thank you again. Really, such an honor.
Yes, thank you so much for inviting us here to share our work with you, and it's such a great opportunity for cross-cultural learning from each other. I'm so thankful to share our work and thankful to hear your cases and to learn from you and to work together to help our children with neuroblastoma. I think this is just a wonderful venue. Thank you for hosting this and inviting us to participate and to meet you. And I also will look forward to being there in Shanghai in 2 years. I'm very, very excited to visit China.
Thank
you again, Dr. Sholler and Dr. Kraveka. For Dr. Sholler, this is a very good result from the U.S. clinical trials and also your help and the support for the NV patients in China as well as in the whole world. Thank you for your dedication and the contribution on behalf of all the Chinese doctors and patients. I would like to extend my sincere thanks to all of you. And also, I would like to thank all the colleagues and experts from China to participate in the webinar from China, both online and offline. And also, I would like to thank our sponsor to have this platform established for us. And also, we hope that in the future, we would have the opportunity. And also, in 2027, May 12th, you would come to Shanghai to meet in person. Thank you.